The purpose of this video is to provide you with the important information about the best surgical treatment for your condition. The reason to consider having a lumbar fusion or what's called a TLIF, Transforaminal Lumbar Interbody fusion, is generally to treat two problems. The first of which is spinal stenosis, which means there's a narrowing of the space for the nerve roots. And the second part of the problem is for what's called a spondylolisthesis, which is just a big word that means that one vertebra has shifted forward on another. Typically, it's the L4-5 level. And as that shift occurs, several things happen. First of all, the space for the nerve roots, the spinal canal, becomes narrowed, and that can cause pain, particularly radiating down the legs. It can cause weakness, and that pain and weakness typically are made worse with standing and walking. And the purpose for surgery for this problem is to relieve that and improve the ability to walk. The goals of surgery are to relieve the pressure on the nerves, open the space or relieve the stenosis, and also to stabilize the segment involved, again usually 4-5. And by stabilize, what I mean is to cause those two vertebrae to grow together or become fused. And in order to cause the fusion to occur, that requires a bone graft. And so typically the disc material is removed and bone graft is packed into the disc space, and a metal cage device which acts as a support is also packed with bone and is placed into the disc space. Screws are placed into the vertebra, what are called pedicle screws, two at each level typically, one on the left and one on the right, for example at L4, same thing at L5, and then those screws are connected with a metal rod on either side, left and right. And the purpose of the hardware, meaning the screws, the rods, and the cage, is to support the spine and to limit motion, because if we want bone to form, then eliminating motion is very important. Much like we would treat a fracture with a cast to limit motion, the hardware is for that same purpose really. With regard to the bone graft, there are two sources for the bone graft. We have to remove a certain amount of bone. That bone is essentially recycled and reused. So it is bone from you, but there is no separate bone graft. There's also the use of allograft bone, which is bank bone. Some patients call it cadaver bone, which is human bone that comes from the tissue bank, which is bone that's harvested from an individual, typically someone who's died from some trauma, and the bone is harvested and processed and sterilized and packaged for uses such as this. It's a very safe, reliable source of bone and is used to supplement your own bone for this procedure. This does carry some risk. There's two types of risk really. One is the risk of anesthesia, which has to do with your medical comorbidities, things like high blood pressure or diabetes, age, other medical conditions, and it may be that you would need to have an anesthesia clearance in order to have surgery. Other types of risk are specific to the surgery. So in order to, again, gain access to where the nerves are so that I can see what I need to see and get into the disc space and work down into the disc space, we have to move the nerves around a little bit, which means that the nerves could be injured or harmed from the surgery. They could be stretched, which could lead to weakness or pain or numbness that wasn't present beforehand. It's possible that the dura, which is the membrane around the nerves, could be torn or damaged and would have to be repaired, which typically, although it does take some time in the operating room, doesn't really lead to any long-term complications. It's possible that even if everything goes very well, no problems during the surgery, everything goes just as we want it to, that the fusion may not heal. the fusion rate is about 92 to 93%, which means that 7 or 8% of patients do not have a solid fusion and potentially could require additional surgery. We don't automatically reoperate on patients with a non-union, which is what we call it if we want the bones to unite or fuse. If that doesn't happen, we call that a non-union. It really, whether or not the person needs surgery depends on their symptoms and so forth. It's possible that they may do fine even with a non-union, in which case wouldn't have to do anything. It's possible that the hardware, the screws and so forth, can be malpositioned. In other words, the screw could cause nerve irritation. When the screws are placed, the nerves are not directly visible. We have to use X-ray control in order to place the screws where they need to be. And if the screw is not exactly in the right place and is causing symptoms, then potentially it would have to be removed. That's very unusual. Most of the time, the hardware, the cage and the rods and screws all stay in permanently. That certainly is the typical situation. It's possible that there can be vascular injuries, which can be quite severe or even life-threatening can occur. Infection is always a risk with surgery, and if an infection occurs, it can require, again, additional surgery. So again, you can see that there's a lot involved. Having said that, most patients do very well. It's unusual to have any of those complications. Obviously, infection is way less than 1%. The biggest complication risk is really the non-union I already spoke about. Nerve injury or dural injury and so forth are very uncommon, and a vascular injury would be extremely rare, or other more significant complications. As I mentioned earlier, non-union is one of the risks with this type of surgery, meaning that the fusion doesn't heal. If a patient smokes or uses nicotine products of any type, it significantly increases the risk of non-union, and therefore it's very important that you stop smoking or stop using any sort of nicotine products, so no patches or gums, etc., until the fusion has had time to heal. It's possible we may draw some blood to check for nicotine exposure in the preoperative period. And one other complication or potential complication with this type surgery is what we call adjacent segment degeneration. And what I mean by that is that we fuse one segment, which takes away one particular joint. That causes an increased stress on the remaining levels, and it's possible that you may develop a similar problem or a similar instability or a spondylolisthesis at a level, usually the level above, although it can also be the level below, which could require additional surgery. And that occurs about 1 to 1.5% per year. So over a 10 or 15 year period, that becomes a significant number, although it's not common in the short term. And that is an unfortunate consequence of doing a fusion, but this is the best way to treat this problem. We don't really have a way to correct the spondylolisthesis without doing a fusion. If we try and just do a decompression without the fusion, that leads to worse instability and typically poor patient outcomes. After surgery, the plan would be to mobilize you as quickly as possible. Some patients are mobilized the day of surgery if the surgery is done early enough in the day to get you to the floor when the therapists are still there. For patients who can't mobilize the day of surgery, certainly the plan is to mobilize you the following morning and basically progress your activity over the next 2 to 3 days such that you're able to be independent with your activity, meaning you can get in and out of the bed, you can walk at least 100, 150 feet, those type of things. Of course, you have to be doing well medically, but essentially that's when you can go home, once you're able to mobilize satisfactorily and tolerate your diet and that type of thing. Typically, patients are in the hospital for 2 to maybe 3 days following this surgery. Kind of depends on the age of the patient and how active the person is before surgery. Essentially, what determines when you can go home is when you're independent with your activity. You have to be off any sort of IV type pain medication, which you probably will be on for the first day or so. You have to be able to eat and drink and void into your bladder and so forth in order to go home. Until the fusion heals, which takes about 3 months, we have to be a little careful about your activity. I do typically like to see patients back in the office about 6 weeks after surgery, because by then most patients are up and fairly active, are off their pain medications and so forth, usually walking at least around the neighborhood a little bit without the use of a walker. And I should mention that a lot of patients will use a walker for the first several days to week after surgery. But by 6 weeks, patients are typically getting around pretty well, off their pain medicine, able to drive, and so forth. I like to get patients started in some physical therapy to begin working on core strengthening and also progressing their walking. Typically by about 3 months, the fusion should be pretty solid and can progress to more vigorous activities, although any repetitive bending, repetitive lifting, any heavy type activities would be restricted for the first 3 months or so. Typically, once the fusion's healed, you would have no long-term restrictions, but again, I think it's important to understand that this treats only one vertebral level, one joint level. Oftentimes patients have arthritic changes at multiple levels, and this surgery does not correct that problem. Even though this surgery doesn't correct all the other arthritic problems in your spine, it certainly leads to significant improvement in the vast majority of patients, and people are able to improve their walking and return to their normal activity with much less leg pain and back pain, and typically don't have any restrictions other than maybe avoiding some very strenuous type activities would really be the only possible limitation.